All right, I think it is time to get us going. So thank you again to our platinum sponsors, gold sponsors, and silver sponsor for their support. Next slide, please. Thank you, everyone. On behalf of NHF, welcome to Pain Explained. My name is Dawn Rodolini. I'm the Chief Operating Officer of the National Hemophilia Foundation. For privacy purposes, please join us in renaming your screen by hovering over your image and clicking on the ... then selecting rename and change your Zoom participant name to first name and registration category. Next slide, please. So to get the most out of this session, please use the chat box or the Q&A box to write in your questions or comments. Our speaker, Lena Volland, will respond to as many as possible at the end of the session, but keep those questions coming as she presents. And make sure to give additional feedback at the end by filling out the evaluation, which you'll receive in your email tomorrow. This presentation is being recorded and will be available to watch online. Next slide, please. So at this time, I would love to introduce you to Lena Volland, Director of Education at NHF. Lena Volland was born and raised in Germany. She received her initial education in Europe and further enhanced her knowledge with degrees in kinesiology and physical therapy. Prior to joining NHF, she was a full-time faculty member at the University of St. Augustine in their Doctor Physical Therapy program and worked as a physical therapist in clinical care and research at a hemophilia treatment center. She is currently pursuing a PhD in translational health sciences with a focus on chronic pain management in people with bleeding disorders, and she has no speaker disclosures today. Lena, welcome. Thank you so much for being here, and thank you for doing this incredibly important session. I will just hand it over to you.
Well, thank you, Dawn, for that lovely introductions, and hello and welcome to everybody who's joining us tonight. I think it's past 8 o'clock on the East Coast, so I very much appreciate that you are still with us. And it's still kind of in the afternoonish, more towards the evening over here on the West Coast where I'm actually living. So while I don't have full disclosures here, I do want to disclose, though, that I am a PT. You've heard that before. And while I've worked in an HTC, I'm also coming from a long time of chronic pain management on the clinical setting before ever entering into the bleeding disorder world. And that has really shaped how I view and see chronic pain and managing chronic pain. So just wanted to add that little lens there. So while it is a little bit in the evening, and I do want to keep this a little bit interactive and also want to build some skills here, you will actually need to get up very quick right now and get a pen and a piece of paper. So please take a minute to grab a pen and a piece of paper.
It might seem crazy what I'm about to say. Sunshine, she's here, you can take a break. I'm a hot air balloon that could go to space. With the air, like I don't care, baby, by the way. Because I'm happy. Clap along if you feel like a room without a roof. Because I'm happy. Clap along if you feel like happiness is the truth. Because I'm happy. Clap along if you know what happiness is to you. Because I'm happy. Clap along if you feel like that's what you want to do.
Very good. Everybody got that piece of paper and a pen and is a little bit more happy now? I hope so. So very quick before we use that piece of paper, why should pain actually matter to you? And why does it matter so much in our bleeding disorder world? Just to give you a little bit of statistics here and a little bit of an overview of what we know from the current research. 40 to 70% of people with hemophilia do have chronic pain. Now, what about the rest? So we don't have correct data or really solid data on people with von Willebrand's disease, as well as ultra-rare bleeding disorders. But I'm just making the assumption here that chronic pain is present in those as well. We also know that 50 to 70% of people with hemophilia treat the pain with opioids. And we do know that 39% of people with hemophilia say that their pain management is insufficient. So their pain is not managed very well. Now, we also know that chronic pain decreases mobility, independence, and quality of life. I think that is not something brand new that I'm telling people, but we also know that it increases depression and anxiety. And we've seen that in a research study published not too long ago, actually. And we're seeing this in people with hemophilia as well. So these are all important elements to keep in mind as we are going through this entire lecture today. So, but there's always this question, what exactly is pain? We are all feeling it, but what is it? So there's an official definition of pain, and it goes like this: an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Now, while I know that sounds really funny and they have a really awkward wording here, I swear it's not a grammar mistake on my end. This is the official new definition of pain. So we also know that pain is considered chronic when it's longer than 3 months, but also it needs to have a negative impact on somebody's life. So that's kind of the theoretical framework of pain, but I want to put this a little bit into a different context to really understand what pain is. So to that extent, we're doing a little bit of a thought experiment here. So there was somebody called Wittgenstein, and he did this beetle in a box experiment that was connected to chronic pain to explain chronic pain a little bit more. So imagine you have a little beetle, and that little beetle is actually sitting in a box. You open that box and you kind of take a peek a little bit at that little beetle that you kind of take a look at what shape is it, what size does it have, what color does it have any other nice features, right? So everybody saw their beetle. Very good. So your beetle might actually look something like this. Maybe it's green, maybe it's a little bit more blue, black, maybe it has an awkward horn on the top, some fangs in the front, right? Might also look a little bit more friendly like this. Maybe it's more of a ladybug, or what we call in German a Maikäfer, which are really, really cute. Or we might have a little bit of a misconception of what beetles we are actually talking about. Maybe your beetle looks a little bit more like this, or maybe we are just completely misunderstanding what we are talking about here, or which kind of beetle. But bottom line is, everybody's beetle looks a little bit different, and everybody has a little bit of a different understanding of what beetle we are actually talking about and what their beetle is shaped in regards to size, color, any other features. The same goes for pain. Pain is an individual experience, and everybody's pain is different. And it's really hard to compare pain between one person and the other, because pain is different, and everybody has their own personal beetle, and everybody's beetle has slightly different features. So everybody has a very personal, individualistic pain experience. So, but again, what is pain? What is it? So sometimes pain is actually a symptom. Now, this is very often true when we're talking in pain in regards to an acute situation, like an acute joint bleed that you might be experiencing. So in that very moment, pain really is a symptom. It demonstrates the presence of something else, like blood in a joint, like some damage that is happening to the tissue right then and there. Now, this is actually really helpful for us from a clinical perspective, because we often use this for a differential diagnosis to find out where's this pain coming from, what tissue is actually problematic here. It also really helps us to give some treatment targets, like where, for example, from a physical therapy perspective, where should we really focus our treatment on? What is the tissue that we need to modify here? Where are really the logjam center issues? It also helps us to assess how effective our treatment is. Are we actually decreasing this very acute pain with what we are doing? Are we effective in our treatment? So in this very moment, pain really is a symptom. And sometimes that's helpful, but not all the time. And here's the problem with the symptom component, or the symptom lens. It doesn't really align with the official definition of pain, because if you remember back, it was defined as an unpleasant sensory and emotional experience. So if we're looking at pain as a bare symptom, that doesn't fully fit. It doesn't tell us the full picture of what pain truly is. So pain always is an individualistic experience. So think back to that beetle, that very personal beetle that you hold in your own box that looks so different from your neighbor's beetle, right? So pain always is an individualistic experience. Now I'm saying experience too, because when we're looking at pain, we can't really differentiate between the body and the mind. The body and the mind are working in conjunction and they're working together. So with that, pain really becomes an experience. So it also becomes an experience because pain itself is impacted by a person's life and by their sense of self. It also includes the person's values and thoughts and how they see the world, their culture, and so many more components. With that, it is really not a symptom, it is an experience. Now, the benefit from actually seeing pain as an experience is that it brings us much closer to person-centered care, and with that also towards shared decision making, because we're seeing the person more as a whole with a pain experience, rather than putting on a reductionist viewpoint and reducing a person down to a symptom. So with that, what we also have to say, no matter how we are viewing pain and what we are including in our pain experience, pain is real. What you are feeling is real, no matter where it is coming from. If you are experiencing pain, your pain is real. So, but what do I mean a little bit more by this experience and by bringing in all of these other elements that are shaping a person and their pain experience? So we really have to employ something called the biopsychosocial lens, or the biopsychosocial model of pain. Now, this is not something new. This has been around for as long as I'm alive. So I'm just telling you how old I am here too, but it has been around for a very, very long time. It's not new, but it still holds very, very much true in the way that we are seeing chronic pain. So I really love this quote here by Adrian Lowe, who is one of the pioneers of pain science and physical therapy. And he always says is, what a patient thinks, feels, and believes about his or her condition will significantly impact their examination, treatment, and prognosis. So again, we can't bubble pain in as a mere symptom, but really need to see it as an experience with all of these components that shape a person. So what do I mean by this biopsychosocial lens? So let's dive a little bit deeper into this, what this actually means. So we have our bio component, our biological elements. So that's really our genetics, tissue damage that is happening. Let's say you're having hemophilic arthropathy. Your tissue is damaged. We're not taking that away. Right? It is system dysfunction, it's inflammation, it's your hormones, it's your diet. All of these components are really making up that biological element of our biopsychosocial lens that's shaping your pain experience. Now, then we have our psychological elements that are driving our pain experience. And that's our thoughts, beliefs, the meaning that we are actually assigning to pain, our emotions, our coping strategies, our behavior, and so forth. And that also differs very much with our experiences overall. And then we have the social components that are driving our pain experience. And that is our family, our friends, our socioeconomic factors. Do we live in an affluent, rich area where we have all the access? Or do we live in an underserved community where our access is really limited? All of those elements are driving our pain experience as well. What about environmental context? What about our culture, society as a whole? All of that is truly driving how we are interpreting our pain. So again, pain is not a mere symptom. Pain is truly an experience that people go through. So with this, it's time to get out that paper and that pen, and let's look into the pain that you are experiencing yourself. So I'm going to give you a minute, and I actually want you to write down on your paper what are maybe some biological, psychological, and sociological or social elements that might be driving your experience of pain. So I'm going to give you a minute, just write a couple down. If you feel like you want to share them, feel free to type them in the chat. If you want to keep them to yourself, that is completely fine too, but do write them down. So I'm going to give you a minute here. good. Everybody got a minute and wrote those down? Yeah. Okay, so keep those in mind as they are driving your personal pain experience and are the shape of your personal beetle. So moving on a little bit. So what is pain? What is it? So let's dive a little bit deeper into the actual pain science component and what pain truly is. So I can tell you pain is a brain output 100% of the time. And before I'm losing all of you, I know that people have always said, oh, it's just all in your head, right? And then many people associate that, but I'm not crazy. I'm feeling this. I'm having pain. Of course you are. So again, all pain is real, but all pain is also an output of the brain 100% of the time. So what I mean by that is you have a lot of information that is coming from your body. So your body will send information in regards to what is going on, let's say in your knee joint. What is going on? Do we have some tissue damage there? Do we maybe have a bleeding episode there? It's sending all of that information up and then goes into your brain, and then it gets processed in the brain. Now, the brain really puts a context around this, and we'll talk about that in a second too, but it interprets all of the information that is coming in from your internal self as well as external information. And then it interprets that, and it makes a decision of whether or not you should be feeling pain. And it really puts it into a context. Now, with that, pain actually often is in response to actual or potential tissue damage. That happens. However, there is actually a very poor correlation between tissue health and the pain experience. And we'll dive a little bit deeper into that in a second. Now, what pain truly is, it is a protective mechanism of your body. Pain is there to protect you. Your brain's interest is in really truly keeping you safe and alive. And pain is really there for you to pay attention to an area that might bring you into trouble. But that also means that the brain sometimes is making a decision of whether or not that pain is really needed right now. Let's say, and this is really going back to thousands and thousands and thousands of years ago, when you were running from a tiger, and that tiger is chasing you because that tiger is very hungry and you look like a really wonderful dinner to him. Now you're running and you're stumbling and you're actually injuring your ankle. In that very moment, your brain might actually make the decision, well, it's more important to run away from that tiger because otherwise we're going to be their dinner than this kind of broken ankle there. So let's keep running. We're not feeling this right now. And then after a while, the threat is gone. Now the brain can actually focus on the injury that occurred. That's kind of where that's stemming from. And we're still feeling this today. And think about today, maybe you are athletic and you have played in a really exciting soccer game and it's down to the last minute and you're just right in front of the goal and you might score and you might have your team win and you kind of hurt that muscle there a little bit, but you just keep going. You don't really feel it and you score and your team wins and you're all good. And then once all of that adrenaline and everything rushes out of your body and you sit down and you relax, then you're actually feeling that pain from that injury that you had. Right? So that is happening in the brain. The brain is interpreting the information it's getting from the internal and external environment to then really make a decision of whether or not you should be feeling pain. Now, I was speaking a little bit about context, and this is really what it is. So again, it's all the information that's coming from inside of your body as well as outside of your body. So that includes all of your senses, your smell, your sight, what you are hearing, what you're feeling, what you're tasting, all of that is included. Now, the other element here that your brain loves to include is your experiences. Your experiences from the past, what you have gone through, what you're experiencing right now, and then what might actually happen in the future. So all of that is really shaping how your pain is interpreting the pain. So to give you a good example, so I have 3 children, and before I had children, my understanding of pain, or what I would consider painful, is very different than how I consider pain now. So I had 3 vaginal deliveries, and it really changed my perception of what pain is and what pain feels like. So my 10 out of 10, because we always love to do this wonderful pain scale, we'll get to that in a second too, but my 10 out of 10 is very different after having given birth to my children than what it was before. My brain learned with the experience, and my brain is putting how I'm feeling pain and how I'm interpreting pain into context with what I have learned and experienced, what my body has gone through. And that same happens when you're having a bleeding disorder. You've gone through one bleed. That is one experience. You've gone through multiple bleeds, and now you're having a lot of hemophilic arthropathy going on. Your brain remembers this, and your brain is putting it into a context. So, with that being said, what is also important here, as I've mentioned before, injury does not equal pain and vice versa. You don't need to be injured to feel pain, and you don't need to feel pain to be your pain does not always occur when you're injured. So we also know this when we're looking at some of the studies, and some of them have been done in people with bleeding disorders, is that when we have, for example, we have done this with some of the manual therapy studies that have been going on. So we are looking into the joints, right? There's a lot of pain, and we might do a wonderful treatment, and that wonderful treatment might be able to decrease our pain. So the patients, after they've gone through either an exercise regime or a manual therapy regime or a myofascial release regime, there are a couple of different studies out there, the pain has actually decreased, but we have not really changed anything really within the joints in a sense of hemophilic arthropathy. They might still have exactly the same or very similar hemophilia joint health score, but the pain has decreased. Now, to give you another example that is often used in pain science, is think about phantom limb pain. And this is really where this basic idea stems from. Now, if you have somebody with an amputation, let's say they really damaged their lower extremity and they had to have an amputation right below the knee. Now, their foot was very, very painful before the amputation. Now we're doing the amputation. And theoretically, if pain would be equal to injury in that very moment, the foot is gone. You shouldn't feel your foot anymore, and you shouldn't have any pain, correct? Right? So, but with phantom limb pain, a person is still feeling their ankle. They are still feeling their foot that was damaged, and they are still feeling that pain. It is because for the brain, that connection hasn't really been made yet. So the brain still thinks it's there. The brain still thinks it's damaged. The brain still sends those pain signals out. Now, what the beautiful part of this is too, it gives us a little bit of a target of how we can treat this, right? How can we really turn that pain dial a little bit down, calm that down, and decrease the pain a little bit? So, talking a little bit more about the different types of pain here, and really bringing that to attention again. So we have a term called nociception. So nociception is really that pain in response to direct tissue damage. So something gets damaged through a mechanical, a thermal, a chemical component. So tissue is damaged in that very moment. It hurts right there in that area that was damaged. It's normally in a much more acute situation. Now, then we have peripheral neuropathic or neurogenic pain. Now, this is pain that is actually in response to damage along a nerve. So that pain is then located in the area that is activated by the nerve. So the damage might not be exactly where you're feeling the pain, but you're feeling the pain where the nerve fibers are going. We are seeing that in some people with bleeding disorders as well, where a nerve gets a little bit pinched, it gets a little bit damaged, but then the pain is radiated to a different area. And then we have this really interesting concept of central sensitization. Now, central sensitization is really happening in the central nervous system. And what that is, it increases the sensitivity to pain. So often this was preluded by some damage that happened before, some nociceptive situation, some neurogenic situation, and then a chronicity with it. So this happened over a long time, the pain was consistent, and then essentially you become more sensitized to pain. So I'll explain that a little bit more as we move on. But again, your pain is real. No matter if it is nociceptive, if it's neurogenic, or if it's central sensitization, your pain is real. What you're feeling is real. So don't let anybody ever tell you differently. Now, here's another interesting thing, and that's really important when we're thinking about central sensitization, when we're thinking about pain signs, when we're thinking about what pain really means, and when we're thinking about different ways of treating pain. Now, the brain system is plastic. I'm not talking about like a plastic container here. I'm really talking about the brain being able to change and modify. And again, we have Adrian Lowe, who said we are biologically coded and environmentally sculpted. So we come kind of with the setup, and then our setup kind of changes depending on the experiences that we go through. So the beautiful part is that our brain continuously changes throughout our life due to the experiences that we go through. So it does that by kind of activating parallel pathways, by activating neurons and pathways that were silent and just pretty much kicking them up. It might also form some new pathways. Now, the beauty about this is that we have a chance to change the brain and how the brain works and functions. This helps us, for example, when somebody has had a stroke. So that's very helpful in that moment. Now, the problem is when we're looking at chronic pain actually causes changes as well in the brain. Now, it causes something that we call smudging of the map. So think about like something is just getting really smudged, like you have a smudge on your window or so, and you can't see completely clear, kind of becomes a little bit blurry. That's what we're calling smudging of the brain. So your extremity, your knee, your ankle, your elbow isn't really that clearly defined in the map of your brain anymore. Now, the other part too, what chronic pain does, it increases the size of representation on your brain. Well, maybe the elbow has a small little area. Now that we've had a lot of bleeds in it, we're having a lot of hemophilic arthropathy in it, and so forth. Maybe that little area of that elbow on the brain now becomes a lot bigger. So there's a lot more pathways, a lot more neurons activated for that elbow. Now, another interesting thing that actually happens with chronic pain is that we get a little bit of a trouble differentiating between left and right. And you would think that's not true, but when we're testing it in the clinic, it really becomes difficult to differentiate quickly between left and right. And there's a lot of tests and assessments we do for that. A kind of interesting side note here, a little clinical pro for you. So, but think about plasticity a little bit from a different angle. So just to make this a little bit clear and drive this home. So anybody plays an instrument out there? So I've tried myself at piano for a couple of years. I never got really good, but probably also didn't practice enough. But think about learning an instrument, of how much that takes. You practice, you might be really clumsy in the beginning. You might not be hitting the right keys. Your violin might sound really awkward. And then you practice and you practice and you practice and you practice. And at some point in time, you become so good, it becomes very automatic. You're changing your brain. You're learning your brain. Now, the downside of this is the brain can also learn pain, and it's really good at learning pain. And that's not a good thing that we want to have, but it can. So let me exemplify this a little bit for you of what we mean by all of this, by increasing sensitivity, by learning pain, and by chronic changes. So let's do a little bit of a thought experiment here. So let's imagine you're having a little bit of a construction site going on at your house. You're walking about, and then, ooh, there's a nail that you're stepping in by accident. Everybody feel that pain from that nail really punching through your skin there? Oh, yeah. Okay, good. Glad we're on the same page. So in a normal status, when we're not having any pain, we're not having any damage, we're not feeling anything, we normally have a basic basic level of where our electricity kind of lies. So kind of baseline. And this is below our feeling line. So anything below this dotted line here that we don't feel, and everything above it, we actually feel. So we will have pain. That's kind of the normal status. Now we're having this whole situation of where our little person here steps into a nail and ouch, we're feeling this, right? So all of a sudden, all of this activity that's happening in the neurons goes up and we're feeling it because we stepped into a pain. It's this big alarm that's going off in the brain because now we caused some damage, right? So in a normal reaction, we see, okay, we have a nail in there. We go to the physician, we get that all pulled out and we'll get it all taken care of. Now, after a while, we're going through the healing process, and then our pain level slowly decreases as we are healing and getting better, and it all calms down. Now, with chronic pain, that is not necessarily what's happening. Let's imagine you stepped into that nail and we pulled the nail out, but then it got a little bit infected and then it healed. And then you kind of stumbled over that foot again. And then it got a little bit better. And then it got infected again. And we ran through some other trouble. And then it finally got a little bit better and so forth. So when we're having a situation where we're having a lot of pain, it either takes a longer time or an injury happens over and over and over and over again. What will easily happen is that our level of where we are feeling and our activity in our neurons, it doesn't go all the way back down where it was before. It kind of stays a little bit higher. It's still kind of below that feeling line, but it doesn't turn all the way back down. It's just right under the threshold of where we are feeling it. And that's essentially that extra sensitivity, that heightened sensitivity that we have created now. So again, if we're having a normal situation, this is kind of our normal line. We're having a big gap here, right? So we're having a large threshold before we're feeling anything. Now, when we're having extra sensitivity, when we're sensitizing our system, our brain, then our threshold becomes really, really small, right? So that large threshold turns into a very small one, which means we don't really need a lot for our brain to say like, oh my God, there's a lot happening. We need to send some pain there, right? So what that actually means is that we turned up that pain dial. So if we're turning up that pain dial and comes to a high volume, that's when our pain increases. It doesn't take a lot for us to feel pain. But when we're turning that pain dial down, then our pain actually decreases too. Now, what we need to put into consideration here too is our brain's ability to differentiate between hurt and harm. Hurt is just that kind of uncomfortable situation, feeling, sensation. Let's say you went for a really good run and now your muscles are slightly sore. That doesn't really harm you. It might hurt a little bit. It might be a little bit uncomfortable, but it doesn't harm you. Harm is actual physical damage. When you're breaking a bone, when you're rupturing a muscle, when something really truly gets broken. Now, the problem is when we're turning our pain dial really high and when we are extra sensitive and we have a very minimal threshold to us feeling that pain, our brain will quickly interpret that as harm, not hurt, but harm. And the response to that is much more significant than to a hurt. So what else could turn up that pain dial a little bit? So this is where I really want to bring in anxiety and stress. And we're all feeling it throughout this last 1.5 years. I don't know what your lives look like. Mine got really stressful and it gave me a lot of anxiety, and that really impacted how I'm interpreting pain as well. So you might have gone through similar situations, but let's talk about how this really is connected to pain and the pain cycle. So we have this whole fight, flight, or freeze situation, right? So fight is where we're getting angry, irritable, and argumentative. Flight, we might actually be avoiding activities, exercise, sunlight, everything. And freeze is just when we're laying in bed, right? Now, the problem with this is really when we're looking into the pain cycle, when we're having pain and then we're adding some anxiety and stress into it, we might actually avoid activity and movement. All of that deconditions our body. It makes it all more sensitive. We're getting more anxiety. That turns our pain dial even more up and we're getting more pain. So essentially, we're spinning ourselves around in a circle. So that is not good. So then also what we do know, if we're having high anxiety and stress, it actually increases our cholesterol and that weakens our immune system. So anxiety and stress is not good for pain. So this is now the time again to get that piece of paper out and that pen out. And I want you to take a look at your own personal pain dial and what does your pain actually make worse? So I'll give you a minute and we'll talk. Write it down, write 3 things down that make your pain worse. Okay, so I hope everybody got theirs down. So for me personally, what turns my pain dial up is when I have a huge mountain of work, when I feel like I can't fulfill all the roles that I play in my life, when I feel I'm failing as a mom, when I'm failing in my job, when I'm failing as an equestrian, when I'm failing in my PhD, that's when I really get stressed out, or when I actually think about my pain. So when I actually tune in and think about, oh yeah, what's going on? Oh yeah, I'm having pain. That's when my pain dial goes up as well. So just to recap this little portion here, and just to reiterate, all pain is real. Pain is always, 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 always an individual experience. Think about the beetle, right? Pain is an output of the brain, and it is based on the interpretation of your internal and external environment. Pain is a really poor indicator of damage. The brain is plastic, and chronic pain leads to an increased sensitivity. Just to recap a little bit, I hope you're still with me. So this is all great, right? But how do we actually fix this? And this is really where we are falling a little bit short of how we are fixing pain or how we are looking at pain. And that's really complicated. I think we have really gained a good understanding of what pain is, and that it's not just a symptom, but really an experience. But now it really comes about how do we apply this biopsychosocial lens to assess and treat pain. Now, when we're looking at the pain assessment, we often don't do a very good job at triangulating kind of the pain expression, the pain subjective and objective measures, and then also the person's environment. I think there's a lot out there that we can do better. We also don't really have a good way of quantifying pain. And I know this is always needed, but how do you quantify an experience? And we'll talk about that in a second too. And then there are many different measures, like which one should we actually use for our bleeding disorder community? Which one is the best? So we don't really know that. So then when we're also looking into pain management, we really have very limited literature on the efficacy and effectiveness of different pain treatment. And those few studies that we have, they're not very rigorous. And they often have kind of this reductionist viewpoint. So we're reducing it down to just one little treatment. So we're not really seeing a big whole real life setting. And then what we're not really looking into, and where we are always falling a little bit short, is do people actually have access to the appropriate team and healthcare providers? There often seems to be a misalignment between the perceptions of what pain a person is experiencing between like the patients, the caregivers, and the healthcare providers. And then we also have organizational and systematic hurdles. So we got to put that into context too when we're thinking about how do we actually manage this. So one thing that I wanted to highlight here, because it's just a personal pet peeve of mine, is how do we actually assess pain? And I talked about that triangulation there, but think about what we often do, right? How do we know that somebody's pain? We might look at them and say like, oh, is their facial expression and what they do, or we might talk to them. We have this really wonderful scale that I'm sure everybody of you in this room has either asked somebody or has been asked, right? Pain scale 0 to 10. Right, we might have these questionnaires that we are filling out. We can actually do some blood tests, or we can do some brain scans, right? We're doing all of this, but this is really assessing the pain experience of somebody. So just to highlight this a little bit, especially when we're looking at this scale, we'll do a quick little thought experiment here. So I want you to actually think about a situation when you have been in love. So maybe take a teenage crush that you have had at some point. Maybe take your child, take your puppy, whomever you can think of. Right now, think a little bit of how it made you feel. Think about how it impacted your thinking. Think about how it impacted your behavior, right? Did you get a little bit more giggly around that person maybe, right? Now, I want to ask you, on a scale from 0 to 10, with 0 being not in love and 10 being the most in love that you could possibly imagine, how much in love were you? Yeah? See the problem with this? Love is an experience, right? It really encompasses our whole body, and the same happens for pain. So we need to find better ways than just having a scale to understand what a person is truly feeling and experiencing, so that we can do an appropriate treatment for that as well. So now think about, how do we actually manage pain, right? So a lot of you might have taken some medication that is out there. There are all different ones, and we can discuss that in a different session. You might have gotten some joint injections. Some of you might have gone so far that you've had a surgery, right? Might it be a replacement? Might it be something else? Maybe you've gotten some acupuncture. There's actually some research on that in people with bleeding disorders as well, might have gone through PT, some exercise program, maybe you've done some meditation. There's also a lot of really great literature on cognitive behavior therapy out there. Maybe you've done some yoga or some other things. What we don't do is that we really look at the individuality of a person. And this is where our assessment comes in, but then our treatment needs to come in too. If we understand pain to be a biopsychosocial issue, then we need to assess it in a biopsychosocial way, and we need to treat it in a biopsychosocial way, depending on what the person actually needs. And again, everybody has their own personal Beetle. So one of you might really need a lot more on the biological component. Maybe you really do need a surgery in that moment. Maybe there's much more social components that are driving your pains, and then we need to work on that. And maybe there's more psychological. It's different for everyone, and we got to find that piece that works for you. So there's not a one size fit all treatment. What we need for this too is an interdisciplinary team approach, and that's exactly what you can receive at a hemophilia treatment center, where you have access to people who can take care of your psychological elements, your social elements, as well as your biological elements, or they can refer you out to the correct person. But it really needs to employ this interdisciplinary team approach. Otherwise, we can't really get a full good handle on pain. So with that keeping in mind, I know there's many different treatments that we can talk about, and we could sit here probably for hours and hours and hours and talk about the different components, right? About medication, surgery applications, braces, physical therapy, orthotics, manual therapy, the benefits of yoga, meditation, acupuncture. There's so many different elements out there. And we could sit here for hours and talk about them. And again, it's different for everybody what works. So, but what I really wanted to do here today is give you a couple of skills that you can actually take home with you and employ tomorrow. And it's really changing a little bit the mindset of pain. So with this, we're gonna think about what turns your pain dial down. I'll give you another minute to write these down and think about this. What lifts your mood? What relaxes your body, what relaxes your mind, and what distracts you? So I'll give you a minute and write that down for you. I hope everybody was able to write some of these down. So for me, it's often spending quality time. All right, this should stop. This is supposed to stop. It's not stopping. So anyways, I'll try to talk loudly over this. Next slide, so the music will actually stop here, excuse me for this. So I also want you to think about what actually soothes your senses. So often when we're thinking about anxiety and we're trying to turn down that dial, it's a good way to turn internally to our senses. So think about this. What do you like to look at? What do you like to hear? What do your most soothing smell? And what is your comfort food? And what is your most comforting sensation? So I'll give you a minute to just think about that. Write it down on your paper if you can. So for me, I love to look at a forest with big green trees. I also love to hear ocean waves. The most soothing smell for me is when I'm actually at home for holiday season, fresh baked cookies. That's one of the best smells. I love Kaiserschmarrn, which is an Austrian food. Actually, my mom always used to make it for me. It's my personal comfort food. I make it for my kids too. So a most comforting sensation for me is a hug for my kids. I think there's nothing better in this world for me than hugging my kids. It just feels great. So I hope you were able to kind of write down a couple of things that are really there for you too, because those are things that you can employ in your day-to-day life. When you feel your anxiety creeping up, when you feel a lot of pain, those are the things that you can actually employ, right? Listen to sounds that you like, have a sensation that you like, eat some comforting food, things that are really bringing some calmness and peace to it. The other thing, because I'm a physical therapist, so I got to put a plug in here for physical activity. And it kind of looks very similar to the other cycle that I showed you before. The problem is when you're having pain, you don't really like to do something. And if it's an acute injury, that's sometimes really the best because you need to just lay low a little bit on that end. But when we're looking into a chronic pain situation, sometimes that's not really the best. We will increase our stiffness, our muscles will get very weak, we then move even less, our whole fitness level declines, we're getting even more weak, and then our movement becomes even more difficult and we're having more pain. So we are again spinning ourselves around in a cycle. The problem is that we really need to overcome our inertia. So sometimes it's really hard of us just getting up, getting moving and starting. Once we start, we're kind of okay, but it's really that inertia that we have to overcome to get up from the couch and actually do something. One thing that really helps with this is making that decision of balance between advantages and disadvantages of making a change. So what will really bring this change that you want to make in your life about? Pros and cons. And if the pros overweight and really move towards it and set realistic goals. We always have this kind of SMART goal situation that you really form your goals as specific, measurable, achievable, realistic and timely so that you can actually be successful. So what do we know in research from exercise for people with bleeding disorders? We actually do know that it increases muscle strength, capacity, it increases our quality of life, it definitely decreases pain reproduction. And then we also know that aquatic exercise are really beneficial, and it might be more beneficial than land exercise, especially if we're really having a lot of pain. It's a good starting point. It is very easy. Now, the other thing that I wanted to bring to you here, what you can really use in your day-to-day practice as you go about it, and again, really overcoming that inertia, is by pacing. Don't make it so hard on you. Set realistic goals, but then really pace yourself. So pick an activity. Set your dream goal, consider your abilities on a low pain level versus a high pain day, average that time, build some cushion time, don't forget about some breaks, and consider weekly activity increase. So what do I mean by this? So personally, I love hiking, and my dream, I would love to go hiking for an hour, 1 day a week. Set small goals, right? So if I have a low pain day, I can probably hike for about 20 minutes, but if I have a high pain day, 4 minutes is enough for me. I can't do more than that. So if I average that out, I'm getting to about 24 minutes total. And then I average that, divide that by 2, it's about 12 minutes. Okay. So I might build in some cushion. So I'll deduct 2 minutes from it. So 10 minutes. Then I do want to build in some breaks. So I normally take 2 minutes off of that cushion time, and then I build in a break about halfway through. So 2-minute break after 5 minutes. And then maybe every week I'll increase it. So I might actually go hiking for 5 minutes, take a 2-minute break, and then do 5 minutes more. And then the week after, I'll try again. So my big, huge thing of hiking for an hour, 1 day a week, all of a sudden became achievable. We call that pacing. You can do that with work too. If you want to return back to work, you can pace yourself back into work as well. The other element is mindfulness practice. And there's many different definitions about mindfulness out there. So, but mindfulness is really a basic human ability to be fully present, aware of where we are and what we're doing, and not overly reactive or overwhelmed by what else is going on. So we're really centering ourselves. And the key elements are really our awareness and acceptance and really centering into the presence. So we begin that normally by checking our body, checking in. Do we have pain? Are we anxious? Are we stressed? We then start a lot of breathing, diaphragmatic breathing, breathing deep into our belly, might scan our body, and then we might actually redirect our thoughts to the present. But we've got to be kind to ourselves because our thoughts love to drift. We always got to wheel them back in. And we always check our body back. So to work a little bit on my mindfulness, things that are really helpful here are meditation and yoga. And I just want to give a plug in here. We do have a wonderful wellness video series at BDC that shows you some yoga and meditation. And I really for you to check that out. John Velasco did a wonderful job, and you can learn this technique really there with him. So go and check it out because we've only a very limited of time here left. So go give that a check. Now, the other thing that I wanted to quickly mention here is negative self-talk. We have a tendency to just talk us completely down. And especially when we are having pain, we might say things to ourselves like, I'm weak, I am sick, I'm worthless, I'm powerless, I'm broken, I'm disabled, I can't do anything. We love to get into that negativity thing. And that's really where we need to move out. So we need to catch that, right? What is our thought pattern? What do we actually think? And are these thoughts helpful or are they harmful to us, right? And then step 2 in this is really check it. Is it true? Am I really worthless? Am I really powerless? Am I really broken? Am I really disabled? Is that true? Or am I just over exaggerating here? And what happened maybe in the past with my experiences, and what am I predicting for the future? So checking, doing a little bit of a fact check here. And then changing it, right? Replace it with kindness, with rationalism, with being compassionate. And sometimes it's good to go a little bit gray rather than black and white, right? We might be like, I'm completely worthless, or I don't have any pain, I can do anything and everything. Go into the middle, like there are some good days where I don't have pain and I'm able to do some things. Be kind to yourself. And then integrate words into your language that are strong and empowering. You are resilient despite having pain. You are strong despite having pain. Despite having pain, you're confident. You are capable. You're powerful. You are worthy. So be kind to yourself. Use good words. Stop that negative talk for you. Last couple of thoughts here, I promise. And then we'll see if we can answer a question or two. So couple of other quick little things is, again, we only have an hour and we can only cover so much. And I really wanted to give you some things that you can easily do at home. But here are just some other pointers to keep in mind. Stay in balance. Make sure you're sleeping enough. Give your body that time that you can get a good 6 to 8 hours of sleep a night. I know that's hard for many of you. Eat healthy and not just one meal. Have really healthy eating patterns. Stay hydrated. Make sure that you're getting outside into nature, you're absorbing sunshine, right? And then really balance out your time alone and within your community. Everybody has a different level of how much interaction people like, but humans are more herd animals. We love communication. And sometimes our communication can also be with a furry friend that will substitute very often too, but really make sure you're staying in balance. Any off balance will actually increase that pain dial, and it might cause you more pain. So in conclusion, we're finally getting there. Pain needs to be understood, assessed, and treated through a biopsychosocial lens. We can't really drop one or the other. Pain can occur with injury, and injury can occur without pain. They're not equivalent to each other. There are many tools available aside from medication to decrease pain, especially when we're looking through a biopsychosocial lens. And there are many challenges that we still have, but those are wonderful opportunities to further our research. We have had an exciting discussion about pain and pain science in our state of the science. So stay tuned for everything that is coming down in regards to research. So with this, I'm happy to answer any questions that might be there in the last couple of minutes here. And I thank you that you went on this great little journey to talk a little bit more about pain science and building some skills that you can integrate here as well. So any questions?
Yes, thank you so much, Lena. So I do have some questions here that came in. It was what an amazing session, first and foremost. I have so many notes. But the first question that came through is, why do people have different pain thresholds? Is it just experiences and exposures? You mentioned brain differences.
Yeah. So it really, think back about the Beetle, right? Everybody has different experiences that they went through, and everybody has a different way of how the brain is actually interpreting this. So it's not just solely the experiences, but it's also sometimes our culture, right? We have different cultural views of how pain is actually viewed. It might be the experiences that your body went through, so that changes it. And it's just different for every person, depending really on that biopsychosocial lens. And some people might just have a lot of damage that's causing a lot of pain too, from just biological component.
Thank you.
Okay.
And then after the slide about exposure, what were the outliers with no previous experience or know-how? So basically, people that don't have previous understanding of strong pain, how do those outliers fit in?
Oh, you mean like how somebody who has never had any pain?
Yes.
Where they are, we just have a normal, every human has like a normal baseline that they are kind of born with. We can actually measure that. So we can measure the electricity that's happening. So everybody has kind of a basic baseline that they are starting with, that everybody has, but then it can change with the experience.
Wow. Okay, thank you. And then pain has mostly been connected to joint damage, especially, within the bleeding disorders community. But are there other aspects in people with bleeding disorders that might cause pain?
Oh, absolutely. So joint damage, yes, there is a damaged joint, of course, that is causing pain, right? There's damage there, but there's other things too. So let's think about women. Let's think about women who have heavy menstrual bleeding, and a lot of times that heavy menstrual bleeding is actually connected to pain. So in that very moment, I'm not having a hematorosis, I'm not having a bleed in a joint, but I'm experiencing another symptom that's very common in people with bleeding disorders that's often coming along with pain. And that pain, of course, can also go into kind of a chronic situation. Now think about this, we're bleeding every single month as a woman, unless we are suppressing our cycle there, but well, menstruation there, but otherwise it's happening every month, right? So every month we would go through that pain. So think about how that actually changes our plastic brain.
And we're anticipating it, and we know that
we are, right?
Yeah.
So again, we have learned with that experience.
Yes.
We know it's coming, it's priming us. So our brain is ready. It's like, oh, it's that time of the month again, right?
Exactly.
So and we have other things like that too. So it's not just joint bleed.
Yeah. Okay. We have 1 minute left, but I'm going to squeeze this last question in because I really love it. What are some of the knowledge gaps in the current research regarding pain in people with bleeding disorders? And then I'm going to ask you to advance to the next slide while you answer that. So I'm going to ask you.
I'll advance to that next slide here. So yes, of course, there is, so we have, outside of the bleeding disorder world, we have a whole field of pain science, and there's so much great research there, really ranging from basic science all the way to big global epidemiological studies. Sorry, we don't really have that in our literature within the bleeding disorder world. We're missing a lot of the basic science components. We really need to go back to the lab and kind of figure out a little bit more of the pathways and what are all the different components that we are seeing here and where are they coming from, right? What is really happening on a cellular level? We need that. We don't really have that in there. But then we need to go more into applying a biopsychosocial lens and an interdisciplinary team approach into our research. Right now, we have a very reductionist viewpoint. We're just honing in on particular little treatments, but that's not really how we're treating pain in real life, right? We're having this disconnect to real life. So we need to do that. And then we need to look into other roadblocks, big lock jams that are limiting access, payment, insurance. What are the big picture limitations, right? What are our health disparities that are driving this, right? We need to do many different components.
Lena, thank you so much. This has been an incredible session. I actually wish we had another at least 30 minutes to continue to go because we had a lot of questions in the chat as well. But I just thank you very much, everyone. Thank you for joining us. This is the last session of the day. I hope that we'll see you first thing, I guess it's Saturday. So like around noon tomorrow, we'll be kicking things off again. Thank you, everybody. And Lena, I'm going to ask you to end the session by clicking end at the bottom of your screen. Thank you, everybody. Have a great night.
Okay. Hold on. I'll do this. Okay. Bye, everyone.
You see it? Okay. Bye-bye. Thank you.
I hope you really enjoyed the time. If you have more questions, feel free to email me. My email can easily be found on the NHF website. Thanks again for joining me. I'm going to end the session now. Goodbye.
Thank you. Good night.